was how, you know, these yeah, the RE rates, you know, for countries that had driven them down, and then we're seeing resurgence. In fact, so I think there's the concern. You know, the virus could mutate a little bit and become slightly more infectious. That can change the reproductive rate. The other thing that honestly seems to have the biggest difference is kind of people's behavior. So if you know, there's more mobility between people. People are being less cautious in terms of kind of social distancing and those factors. That will, you know, more people will get infected, and that RE number can go up. If we look at this graph, it can kind of explain, or you can kind of see that a little bit. So this was, again, the early data that we have way back in March, April. If you look on the left side of this graph, you know, there's really wide kind of confidence intervals. So that's how sure we are of that data. That's that shaded part of the graph. But the RE was, you know, way up around 3, 2.5 for a good chunk of March. That would have been when probably lots of people were getting infected. We didn't quite know it. Testing wasn't as available then. Full kind of lockdowns didn't happen until later in March. And then once we kind of drove mobility down, that number rapidly declined. Again, we're comparing Eastern and Western Washington, which I think is kind of interesting for Skamania County being right on the border. And Washington, like I said earlier, Eastern Washington, that number has not until recently been below 1, and we've seen that in Eastern Washington. They've really struggled. Certain counties, you know, have had really high rates of hospitalization and cases in general. Western Washington did great in, you know, late April, May, June, and then kind of late June started seeing that spike again, getting, you know, 1.5, 1.6, and then falling again, and creeping around 1.1 essentially right now. This is hospitalization rates, daily hospital admissions across the state, kind of looking by age, and also Eastern and Western Washington, kind of seeing cases on the left, daily hospital admissions on the right. In Eastern Washington, kind of a general increase across the board amongst almost all ages. You can really see how much higher that 70 plus age group, you know, their case numbers stay relatively low, but, you know, their hospitalization rates, you know, stay pretty high. Similar in Western Washington, although the curves are a lot smoother. So we can see that spike in younger people around July, 0 to 39. They, like I said, drove most cases, but also spikes in 40 to 69 age group as well. Less significant increase in over 70. And then some correlation with hospitalization rates. Obviously, 0 to 39, even though a huge spike in cases, not really a significant increase in hospitalizations, but both the older groups have seen more hospitalizations lately. This is from their not the most recent report, but from the report before that, which is a little bit hard to understand, so let me try to order it into. Color is cases per 1,000, so essentially the more red it gets, the higher the rate. On the left side is age, and then on the bottom axis is over time. So this is comparing Washington and Florida. I hope we don't end up like Florida, but it is an interesting kind of thing to compare to. So Washington, you can. What was that?
What is the date of this slide?
Okay, so this was, I'll have to get that. I will get that for you, but it's from, hold on, let me think about this. It is the 11th. It was like the end of July, essentially.
Yeah, because I saw a presentation, I forget who the guy was that did the modeling on this, and he predicted in 3 weeks that Washington would be looking like Florida.
Yeah, and yes, and that was, a fear that we had, because if we look at these graphs, we unfortunately they look pretty similar. It almost looks like we were just a little bit behind Florida. I think, and you can kind of see this in those graphs.
To get a current one.
Yeah, unfortunately they didn't create this for their most recent report, because I was curious too. I think you can kind of see it in the Washington part. So that age distribution, rates in the higher age groups climbing slightly, but maybe not as severe as Florida saw. Essentially, is kind of what I'm hoping is what we're doing, and that's why we haven't seen this huge jump in hospitalizations. And I think we have seen a very kind of slow increase in hospitalizations, and I think that's because we are seeing more cases in those higher age groups over time. But if we can suppress it and keep it from turning into those red colors that we saw in Florida, orange and red, we should be able to hopefully prevent our hospitals from being overwhelmed. Yeah. Great points. So Skamania County, Kirby covered most of these data points already. I did want to touch on the Epicurve for Skamania County. So Epicurve, number of cases kind of each day. We see our spike in the middle of July, and certainly more cases since then than prior to that, but not as many. I think, like we talked about before, we had a significant jump around or after the 4th of July. And yeah, we'll see what that looks like going forward. And I think we're missing a couple cases from the most recent dates that went through, like August 4th, I believe. That's that last case that's there. This is from the state website, so it's not quite, I think it's missing a couple cases. Oh, yes, and so I wanted to relate that to our school discussion. So Kirby and I have been meeting with our superintendents weekly and kind of talking through these numbers. So last week, the state released this kind of guidance for schools. And it's guidance, it's recommendations, it's not a requirement, as some states have done. They divided basically COVID-19 activity level into 3 different levels. High being above, so this is 75 cases per 100,000 people over a 14-day period. So we take those numbers that we have. In our case, there'd be a slight multiplication because we don't have 100,000 people, and then we tally up over all the cases over a 14-day period. We are doing a look back a little bit. So, for example, I'll show you on the next slide with our data, but we'd be looking from today, looking back like 6 days. We look at the 4th of August through the 22nd of July, and that gives us a 14-day window. And that's how we would calculate that number. So the idea being that for communities with high levels of COVID-19, the risk for schools is a little bit higher, obviously, that a student or faculty member could unknowingly bring the virus in and potentially spread it. If we're able to get lower community activity level, it should be safer to open schools. There's less of a chance that a student or a staff member could bring in the virus, potentially expose other people, and potentially, honestly, cause further disruption. So how I view this is, if we get our case counts to moderate to low activity, start bringing kind of slowly add in-person learning for kids, I think we have a better chance of honestly keeping kids in school longer, and hopefully less disruption during the school year because of potential closures and that sort of thing. So we're looking at those rates. They also, talk about increasing trend in hospitalizations or other cases, test positivity over 5%. So in that high level, essentially distance learning with limited in-person learning for smaller groups. So for the highest needs kids with disabilities, homeless children, and maybe some young learners that might be able to come to school in very small groups. In that moderate level, which I'm hopeful that we'll get to soon, that's when they say distance learning, but consider expanding in-person learning to elementary students. And then over time, adding hybrid in-person learning for middle and high school students. If we're continuing to see kind of limited COVID transmission. So I think it's going to be a little bit of a dance. We have some in-person learning and we kind of see what happens. The reason they recommended starting with elementary students is some of the data that we have right now is that the youngest kids, while the chance of them spreading the virus is still possible, it's less likely than in older kids. So over 10 kids seem to spread it honestly as easily as adults. Under 10, they can still spread it, but it's a little bit less. So we have that coupled with the fact that obviously distance learning is just harder for younger children. I think it makes more sense to bring them in first. And then if we get cases to that low level, so encouraging full-time in-person learning for all elementary students and a hybrid learning model for middle or high school, and then adding in as time goes on. Talking specifically, let's see, here we go. So this is, again, from the state. So this is that rate that we're looking at. So again, seeing our spike in July, for a short period of time, our rate was over 200. And most of July, it was over 100. Most recently, we have seen a slowdown in cases reported, but it's honestly bouncing up above 75 and below 75. What I talked about with the school districts is before changing in modalities, I'd really like to see that on a decline for at least 2 weeks consistently. And once we get into a place where we're confidently in kind of moderate transmission, then we need to, then we start potentially adding some students in. What I don't want to do is if we have, this is especially important in Skamania County because of the population, if we have a spike in cases and we jump above that 75 number, I don't want to automatically jump to, well, we have to go all distance again. I think we're going to have to kind of evaluate the situation and see if, okay, so we jump above that number. Do we feel that this is community spread? Do we feel that there is a risk to the student population, to the staff population? What are the circumstances around those cases? And that hopefully will inform. I don't want to do this yo-yo kind of back and forth, in person. At least that's what I want to avoid. Obviously, we will see what happens when we get there. Okay, common questions. I think I briefly touched on this last time. So, just defining what exactly a COVID-19 death is. So confirmation is a positive COVID-19 test and death certificate saying that it caused or was a contributing factor. That's considered a confirmed. Pending is they had a recent positive test, but their death certificate is not done yet. Suspected is they have a recent positive COVID-19 death, but it's not listed, and then some follow-up is being done to either rule out or confirm that. And then in a few cases, in this report DOH did July 14th, they recognized that, there were examples of homicides or overdoses or car accidents where people have had a recent positive COVID-19 test, but obviously it wouldn't make sense to keep them as a confirmed COVID-19 death. So those were removed. In going forward, I think they're going to use this process. But they haven't released another detailed report yet. I'm not sure if they're going to do that monthly or not. But
can I interrupt?
Of course.
Doctor, can I interrupt here?
Yeah, of course.
So going through this last slide, so you say according to the state, they're going to now start breaking it out by confirmed, pending, and suspected?
Yes.
So like if our county, it says number of deaths 1, would we say which of those 3 it was, or?
We could. Right now, our process is just doing confirmed ones, essentially. And obviously we haven't had any of the other we haven't fit in any of the other categories. So what I've done with counties that have smaller numbers of deaths is if I have access to medical records, and I have no there's no question in my mind that they're going to call it a confirmed death, then we call it confirmed. Otherwise, we just wait for the death certificate. So that's kind of the process that we've done.
Well, the total number of deaths for Washington State, are they going to go back and try to sort those out into 3 categories, or are they just?
Yes, they did that. They did that on that report on July 14th. So they removed 4% of the cases, and then 5% were suspected, and I can't remember how many were pending. 89% were confirmed in that report. Yeah.
Thank you.
Yeah. This was an interesting slide. I borrowed this from Dr. Melnick, which just comparing COVID-19 to other causes of death. And this is nationwide. So we've had 162 confirmed deaths, 162,000 confirmed deaths in the United States as of yesterday, according to the CDC. Looking at our kind of most recent mortality numbers in the U.S., this is also from the CDC annual numbers. This was from 2017, so a whole year's worth of deaths. So heart disease and cancer were number 1 and number 2. 647,000 and 599,000 accidents, 169,000. So COVID-19 is, I guess, now number 4, or likely would be number 4 if we looked at it from an annual kind of perspective. Again, this is we're comparing a 5-6 month period versus a whole year, but I think that was an interesting way to kind of keep this in perspective. I'm hopeful that COVID-19 will not remain this way. That would be terrible if it remained essentially the 3rd leading cause of death in the country. Obviously, if we are able to slow transmission and either through vaccines or other methods.
Dr. Stephen Krager,
I think our
who's
vaccines
the health
on
officer
the
for
best
Skamania and
the other option would be, really effective treatment that could cure someone,
updating the Skamania County Board of Health on August 11th,
but
2020.
we're not quite there yet. I'm going to touch on that a little bit later too. Okay, I wanted to, go ahead.
Can you go back to the slide? I have one just ignorant question. The one that has 50,633, the nephrotic syndrome, I have no idea what those are.
Yeah, that's kidney disease. Yeah, sorry.
Oh, okay.
Yeah.
Okay.
So nephrology is, the study of the kidney. So yeah, those are all kind of ways your kidneys can fail, essentially.
Okay, thank you.
Yeah. Mm-hmm. So I wanted to touch on this because it's changed since we initially, and I think some people are pretty aware of this, but I don't want to assume that of everyone. So kind of what exactly COVID-19 symptoms can be. And it can appear, 2 to 14 days after exposure to the virus, which is why we ask people who are exposed to stay home for 14 days in case they, are one of those people that it takes 14 days to develop symptoms. Fever and cough and chills and shortness of breath are kind of the classic ones that people think of, but fatigue, muscle aches, those are also common with viral illnesses. The new loss of taste or smell can happen with some viral illnesses, but not nearly as often as it seems to happen with COVID-19. Some people that's their only symptom, and it's really interesting. They otherwise feel completely fine. Sore throat, congestion, nausea, vomiting, diarrhea. I want to point this out just as another way that the virus kind of makes things difficult for us. If it fit into a category, it only caused a cough, a fever, that would make things a lot simpler. But it causes such a wide array of symptoms in people that it can mimic a lot of other viruses, unfortunately, and bacterial infections. I wanted to touch on where we're at in regards to treatment. We have 2 medications right now that we have pretty good evidence that they help, especially people with kind of severe illness that are hospitalized. So remdesivir is kind of antiviral medication that seems to improve outcomes for people. It certainly doesn't cure the disease, but it makes you less likely to die and more likely to recover more quickly if you're in ICU. Similar effects with dexamethasone. Lots of drugs obviously being under evaluation and being researched. So plasma from people that's a part of your blood. So people who've been infected, you can donate plasma and potentially being used as a treatment. There's an inflammatory kind of molecule called IL-6 that seems to drive a lot of kind of our body's overreaction to the virus. If we inhibit that, then that's another one. Chloroquine is still, there's been a lot of obviously mixed results about those drugs. Some of the larger ones seem to show that it's not very effective, but there's still research ongoing. And this is probably my favorite topic, is vaccines. And let's see, this might be a week out of date, but 165 vaccines currently under development for COVID-19, 27 which are in human trials, which is pretty amazing, and 6 which are in phase 3 trials, which is the last stage before approval. Before people get too excited, it is also the longest phase, and they're still very early in those phases. Phase 3 is the part of research where you give the vaccine to a large number of people, and then you see what happens with them. You compare them to a group that didn't get a vaccine or got a placebo vaccine, and then you see was the group that got infected. First of all, was it safe for them? Did they develop antibodies? And then did it actually prevent you from getting the illness when you look at large groups of people? There's been a lot of chatter about, what it means to be immune, and are you immune after you get the disease? We still don't know a lot. There's different types of immunity, so it's not always just antibodies that we talked about, but there's other parts of your immune system that play a role. We do know that the more severe infection that you have, the longer lasting your antibody response is going to be, which potentially could mean that you're going to be immune longer. And in other viral illnesses, vaccines actually produce a more durable antibody response than even a natural infection. So it's hopeful